Well, let's try and work out what's going on in this condition of heart failure. Now here I've drawn a little heart. We've done this in detail in other videos and I'll post the link. This is the left side of the heart here, and this is the right side of the heart here. So what's happening here in heart failure? So briefly, we've got the left atrium, the right atrium, the left ventricle, the right ventricle. In orange here we've got the mitral valve or the bicuspid valve, and in this pinky colour here we've got the aortic valve, because this is the aorta leaving the left ventricle. In orange here we've got the tricuspid valve between the right atrium and the right ventricle, and between the right ventricle and this is the pulmonary artery here, the pulmonary artery going to the lungs, that is the pulmonary arterial valve. And it's useful to think about the contractile layer of the heart. We have the thicker left ventricle here, the cardiac septum in the middle. This is the myocardium, the contractile muscle of the heart. The myocardium. So this is atrial myocardium at the top, ventricular myocardium, and the left ventricular wall is thicker than the right ventricular wall. Because this left ventricle is pumping blood into all of the systemic circulation via the aorta. So this is pumping blood to all of the body. This represents the body here. All of the body receiving its blood supply from the aorta. But then once the blood's been through the systemic capillaries of the body, it needs to drain back in the venous system, in the body's systemic venous system, via the inferior and superior vena cava, back to the right atrium. So this is the aorta and the systemic arteries taking blood to the body. This is the systemic veins draining into the inferior and superior vena cava, going back to the right atrium. And the pulmonary artery is taking blood to the lungs. Here we have the lungs. Blood circulating around the lungs. And then the blood's going to drain back from the lungs in the pulmonary veins from each lung. And actually in humans there's 4 pulmonary veins drain into the left atrium. So that's the normal situation, that's the normal circulatory system. Now if we start thinking about the left side of the heart first of all, the left ventricle. If the left ventricle is failing, now we're going to define heart failure. Heart failure is the inability of the heart to pump out enough blood to meet the metabolic demands of the body. Or another way to put it is, heart failure is when the cardiac output is insufficient to meet the metabolic demands of the body. So normally the left ventricle is contracting, and it has a particular rate, the heart rate, say 70 per minute, and it's pumping out so much blood per contraction, at rest say about 70 mils. That's the stroke volume. Cardiac output is those two multiplied together. So cardiac output equals heart rate multiplied by stroke volume. The cardiac output is the volume of blood, and it's the volume of blood that needs to get to the body to supply the metabolic demands of the body. So the left ventricle's job is to pump out enough blood to get enough oxygen, nutrients to the body, enough oxygen, glucose, fatty acids and other nutrients to the body to meet the metabolic demands of the body. Because the body is made of many cells. People put out figures for this from time to time. I think the last one I read was about 70 trillion 70 trillion cells in the body. So in the body we have lots of cells, nucleus. But of course in the cytoplasm we have these mitochondria, these metabolizing units. Probably several hundred mitochondria. And they need the oxygen. So the reason we need to get the oxygen to the body is in order to get the oxygen to the mitochondria so they can metabolize. And of course they then produce their waste product, they produce the carbon dioxide. So the blood going back to the right side of the heart in the venous system contains less oxygen and more carbon dioxide. That's why we draw it in blue traditionally. So heart failure is when the left ventricle is unable to generate sufficient cardiac output to meet the metabolic demands of the body, meaning that the cells of the body are not getting enough oxygen and enough nutrients to meet their metabolic demands. Now, in rest at the moment, you're probably using something like 250 mils of oxygen per minute. But if you go out for a sprint, that'll go up to about 1500 mils of oxygen. Because if you're young and fit watching this, your heart can beat faster, it can compensate. But someone with heart failure, they'll lose this reserve. The left ventricle can't work harder because there's a dysfunction of the left ventricle. It's unable to generate sufficient cardiac output. So even though the patient might be okay at rest, they might be getting enough oxygen to their body tissues at rest because you need a relatively small amount. When they start to exercise and they increase their oxygen demand and they increase their metabolic demand, the left ventricle will not be able to compensate for that. And as a result, they'll be deficient of oxygen. And as well as that, the carbon dioxide won't be getting washed away properly. So there won't be enough oxygen to meet the increased metabolic demand, so the patient will become short of breath and they will become fatigued. And these are the classic features, of course, of heart failure: short of breath and tiredness. And they'll become tired and fatigued quickly because they're not getting enough oxygen. But then as the condition worsens, their exercise capacity goes down and down because the left ventricular function is reducing, until eventually the patient might be short of breath and fatigued, even at rest, because they can't generate this minimum amount of oxygen that the body requires. So that quite nicely explains the shortness of breath and the fatigue, because of course all the muscles in the body need the oxygen, otherwise they're going to get tired. The brain needs oxygen or it's going to feel tired. And in heart failure, the cardiac output is insufficient to meet the metabolic demand. Now, that's one thing with heart failure, those features. But let's think a little more now. So normally in you, the left ventricle is pumping out maybe 70 mils of blood at rest, more when you're exercising. Now, if there's a left ventricular dysfunction, if the left ventricle is not working properly, then what's that going to do to the stroke volume? What's that going to do to the volume of blood the heart can pump out per contraction? Well, if it's contracting nicely and efficiently, it's going to pump out a good stroke volume. But if the left ventricle is not working properly, if there's a degree of left ventricular failure, it's going to pump more weakly. The strength of contraction is going to be reduced, and that means it won't be able to eject as much blood as normal. So the stroke volume is going to go down, reducing the cardiac output. It's not ejecting as much blood as possible. But if it's not ejecting as much blood as normal, can you see that instead of being pumped out, some of that blood is going to be left in the left ventricle? It's going to be left there. There's going to be what we call a residual volume. And if there's a residual volume of blood in the left ventricle, is that going to make it easier or harder for blood to go from the left atrium to the left ventricle? Well, if this is already partly full, it's going to inhibit the flow of blood from the left atrium to the left ventricle. So we can get a backlog of blood into the left atrium as well. Now, is that going to make it easier or harder for blood to leave the pulmonary veins? Well, clearly it's going to be harder. So we're going to get a backlog of blood in the pulmonary veins, leading to a backlog of blood in the lungs themselves. Just like a traffic jam, isn't it? If the car gets jammed on the bridge, if this is the bottleneck, there's going to be a backlog. So because the blood's not getting pumped out there, it dams back there. That's going to increase the pressure, and the increase in pressure is going to dam back. So there's going to be an increase in pressure in the pulmonary veins, these are the pulmonary veins, and then in the lungs. Now in the lungs, of course, we have lots of pulmonary capillaries. So the capillaries are thin-walled structures. Here we have capillaries with these thin endothelial cells. And in a pulmonary capillary, the blood is going to enter here at a reasonably high pressure. The pressures aren't high in the pulmonary arterial system, as we'll see later, but there's going to be a pressure there, and that's going to result in the formation of tissue fluid. So we're going to get the formation of some tissue fluid. Quite normal. There's a degree of tissue fluid in the lungs. Not a huge amount, but a bit. And that's normally sucked in by the osmotic effect of the plasma protein. So these big plasma proteins are generating an osmotic effect. And at the venous end of the capillary, here, because this is going into the pulmonary venous system, that's going to be sucked back in. The water's going to be sucked back in because the pressure at the venous end of the capillary is normally less. So the tissue fluid forms at the arterial end because the hydrostatic pressure, the blood pressure, is greater than the osmotic pressure. And in physiology, the fluid is reabsorbed at the venous end because the hydrostatic pressure is lower and the osmotic pressure is greater, so it sucks it back in. But now, can you see we've got a backlog of blood here in the lungs. So there's a backlog of blood in the pulmonary veins here. And of course the pulmonary capillaries drain into the pulmonary veins. So if the veins are congested, that means the blood can't drain out of the capillaries, so we get a backlog of blood in the capillaries. And if we get a backlog of blood in the capillaries, that's going to increase the pressure in the capillaries. Now, if we increase the pressure in the capillaries, is that going to make it easier or harder for the tissue fluid that's in the lungs to get back in to the capillaries, to go back to the heart? Well, I think you can see it's going to make it harder. So we get the accumulation of tissue fluid in the lungs. And the accumulation of tissue fluid in the lungs is called pulmonary edema. Pulmonary means to do with the lungs. Edema is the excess of tissue fluid. In the States, of course, you don't have the O. Now, that means we've got much more tissue fluid in the lungs than we would want in normal physiology because of this backlog effect. And of course, normally in the lungs we have these alveoli, the air sacs. The oxygen normally comes in, the oxygen goes into the capillaries, the carbon dioxide goes from the capillaries back into the alveoli to be breathed out. It's the carbon dioxide, goes from the capillaries back into the lungs to be breathed out. But now we've got pulmonary edema. We've got too much fluid in the lungs, excessive fluid in the lungs. And this tissue fluid seeps into the alveoli and they become waterlogged. This is the pulmonary edema. Clearly that means that the oxygen is not going to be able to get into the blood as normal. The carbon dioxide is not going to be able to escape as normal. And so the pulmonary edema is going to reduce the effect of gaseous exchange. Now, when someone's lying down, when you're lying flat, so here's someone lying down, This is the chest here. The legs there. So we have the lungs in here, obviously. Now, when someone's lying down, the pulmonary edema, if it's present, tends to go all over the lung field like this, and they find it very difficult to breathe. But then if we sit them up, so the patient's now sitting upright, what happens now is the pulmonary edema tends to drain to the bottom of the lungs and collects in the bottom of the lungs. You can actually see the fluid lines if you look at x-rays. But the good thing about that is it leaves the top of the lungs fairly clear, so the oxygen can go from the upper lung fields into the blood, which is good. And when someone has difficulty in breathing lying down, that's called orthopnea. Ortho actually means straight. They have difficulty in breathing when lying down. And the treatment, of course, is to sit these patients up. So when patients come into hospital with heart failure, we nurse them sitting up or leaning forward to maximise the clear areas of lungs over which gaseous exchange can take place. And what patients will often complain about is they'll say, well, I go to bed and I go to sleep, but then an hour or two later I wake up and I can't breathe. I have to sit up and walk around to be able to breathe again. And that's because when they're lying down, the fluid is going all over the lung fields, giving them this pulmonary edema. And of course that greatly exacerbates the feeling of shortness of breath. But if we carry on, if the lungs are congested with blood, if the pressure in the lungs is higher, is that going to make it easier or harder for the blood to get from the pulmonary artery into the lungs? Well, again, I think you can see it's going to make it harder. So there's going to be a backlog of pressure in the pulmonary arteries. There's going to be an increase in pulmonary artery blood pressure. It will generate a pulmonary arterial hypertension. Now, is that going to make it easier or harder for the right ventricle to pump blood into the pulmonary artery? Well, I think you can see it's going to be harder. It's working against an increased outflow resistance. So the right ventricle has to work harder. And what that will mean is the right ventricle will enlarge to compensate. But over time, the enlargement causes failure and we'll get failure of the right ventricle. Now, you can get a primary failure of the right ventricle as well. That can happen, but very often the right ventricular failure is a complication of the left ventricular failure. So now we've developed a right ventricular failure because of the high workload of the right ventricle over a long period of time. Can you see that when the right ventricle contracts, because we've now got a right ventricular failure, that's not going to be able to pump out enough blood either, so there's going to be blood left in the right ventricle. Can you see that's going to dam back to the right atrium, and that's going to make it harder from the blood from the systemic veins to get back in to the right atrium, so the blood's going to dam back in the systemic veins. And you can notice this because the patient will get raised jugular venous pressure in the neck veins. But that's going to mean that there's going to be an increase in pressure in the systemic veins, meaning the blood finding it harder to drain from the body. The body is going to become congested with blood. Now, if the body is congested with blood and there's increased pressure in the systemic veins, then imagine now that this diagram represents a systemic vein. So normally in the systemic veins, the tissue fluid is formed at the arterial end of the capillary because the blood pressure is greater than the osmotic pressure. Normally it's reabsorbed at the venous end because the osmotic pressure is now greater than the blood pressure. But if the blood's damming back here and the blood from the capillaries can't drain into the systemic veins because the pressure in there is high, that's going to increase the pressure in the systemic capillaries now. So if you increase the pressure in the systemic capillaries, that's going to make it harder for the tissue fluid from the systemic tissue spaces to get back into the blood. That's going to collect in the systemic tissues of the body, and that's going to give rise to systemic edema. affecting the body. And this edema is gravity dependent, so if the patient's sitting up, it tends to go to the lowest parts of the body, and we see it in the ankles and the feet initially. But it can then spread up the legs as the heart failure progresses. So we see the nature of the circulatory system tells us why the patient is short of breath. They're short of breath because there's insufficient left ventricular function to meet the metabolic demands of the body, and they can be short of breath because they're developing pulmonary edema because of this backlog effect. The lack of oxygen is also going to cause the undue fatigue. And we also see why left ventricular failure will initially cause pulmonary edema, and we see why right ventricular failure will lead to systemic edema. Now, in practice, this develops over years, so the right and the left ventricles clinically often appear to fail at the same time. And we see these classic features of breathlessness, fatigue, and the edema, the accumulation of pulmonary and tissue fluid.